From Microbe TV, this is Infectious Disease Puscast, episode 29, recorded on May 24, 2023. Hey, I'm Daniel Griffin, and joining me today is Sara Dong.
Hey everyone, I'm Sara Dong. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire.
You know, it is actually growing. You know, I mean, Mark Crislip used to make that comment, and I don't know how much his empire was growing, but so Sara, where are you today?
I'm still at home. I'm just in an unusual corner of my house because I'm boxing things up. So I was trying to find something that made it still look like I had had things together, even though it's a mess behind the camera.
Okay. Well, I will let you know, I am wearing my Prion bow tie today. And that's a little bit of a foreshadowing. You know, if you stick with us past 21 minutes, if you make it to 30 minutes, y'all will hear about something really exciting.
Well, Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So, on to the literature, shall we? I will kick us off by starting with our viral section. Remember to listen to TWIV for other viral related updates. I had some pretty great prelim results that were, this is a little bit different. It's sort of like a press release / conference update from ESPID this month. So for those who are not familiar, that's the European Society for Pediatric Infectious Diseases. So a conference that I'm hoping I'll be able to go to next year. This is from the Harmony Phase 3B study trial results of nirsevimab against RSV lower respiratory tract infection hospitalization for infants. So nirsevimab is a monoclonal antibody with an extended half-life that is licensed in the UK and the EU to protect infants against lower respiratory tract infection due to RSV during their first RSV season. So these are some pragmatic trial results, which was conducted in the UK, France, and Germany. They provided this MAB versus no intervention, and so far have had a little over 8,000 infants randomized, with about 4,000 in the nirsevimab group and about 4,000 in the no intervention group. The efficacy against RSV lower respiratory tract infection hospitalization was 83% for the patients who received the monoclonal antibody, and it reduced severe RSV disease by about 75% and reduced all-cause lower respiratory tract infection admissions by 58%. So that's super exciting and big numbers. And I think the bonus here is that this is actually not even an IV infusion. It's an IM injection that can be given kind of like an immunization. So we've had a lot of fun news and updates on the RSV front recently.
All right. I'm very excited about this. Now, I don't know how many other people are excited about the naming of MABs, but you know, if you look closely here, right, it starts with MAB, monoclonal antibody, VI, so it's for viruses, but then it's NurseVMAB, right, for like almost like nursing mothers for the little kids. So
I know
really clever.
Yeah, I know there's that, like, you can almost make like a little cheat sheet to figure out what the MABs are against.
Yes.
And I never keep it in my brain, though.
That's okay. Make room for all the actual important stuff. And we will move on to another MAB. This might be a bit on the esoteric side, but I have seen and take care of a number of people with HTLV1. So the article, Mogamulizumab. So let's sort of figure that one out. For treatment of HTLV1 associated myelopathy, tropical spastic paraparesis, a single center US-based series published in CID caught my eye. It suggested that HTLV1 induced expression on T cells might drive much of the pathology of HTLV1 associated disease. So the Mogamulizumab, or let's just call it MOG, is a monoclonal antibody that binds CCR4 and leads to the clearance of HTLV1 infected CCR4 positive cells. A phase 1-2A study in Japan evaluated MOG for the treatment of HTLV1 associated myelopathy, tropical spastic paraparesis, we'll call that HAM-TSP, and reported decreases in HTLV1 proviral load and neuroinflammatory markers with clinical improvement in some participants. Administered the MOG at 0.1 milligram per kilogram every 8 weeks to individuals with HAM-TSP as a compassionate and palliative treatment, and patients who received MOG had 1, a positive peripheral HTLV1 antibody, 2, progressive myelopathic symptoms, and 3, a diagnosis of HAM-TSP. This experience, very small, included 4 patients, and the 2 patients with milder baseline disease reported symptomatic improvement and saw reductions in the different scores that they used. Now, the other 2 patients showed no improvement, but I will note all 4 developed rashes after receiving MOG, and this was a treatment-limiting event in some cases.
My next one, it's technically a smidge before the 2-week window, but I forgot to include it in the last episode and I wanted to mention it, so I still put it in for this time. The article was entitled Revised Protocol for Secondary Prevention of Congenital CMV Infection with valacyclovir Following Infection and Early Pregnancy. For a little bit of context, there was a previous RCT from the authors' center that found valacyclovir effective in reducing the risk of congenital CMV infection in women infected early in pregnancy with an odds ratio of 0.29. But the results were statistically significant only for women infected in the first trimester. And for those infected with primary CMV in the peri-conception period, the treatment did not significantly modify the rate of vertical transmission. So the thought was that this discrepancy was presumably from later initiation of treatment after the primary maternal infection. We don't have a ton of data on that interval from maternal infection to fetal viremia, and the current guidelines recommend amniocentesis at 6 to 8 weeks after whatever the assumed time of infection would be. So they went and revised their protocol to do this study. Took a look at the women with primary early CMV infection treated with valacyclovir in this window, which was 2020 to 2022. And their new revised criteria, looking at if that woman or that pregnant person had a primary CMV infection acquired 4 weeks before and up to 3 weeks after the recorded date of the last menstruation or in the first trimester. So they started treatment up to 9 weeks from the assumed time of infection in those who were infected in the peri-conception period, or up to 8 weeks from the assumed time of the maternal infection, and before 18 weeks of pregnancy in women infected in the first trimester. So I know that's a ton, but they compared the original placebo and control arm. The women in the study agreed to have an amniocentesis at 20 to 22 weeks. They get valacyclovir 8 grams for the whole day, divided into they had 2 to 4 doses until the date of their amniocentesis. Of the 195 women offered treatment, 17 were excluded for a variety of reasons. So they ended up having 178 women who took valacyclovir, included 59 who were infected in the peri-conception period and 119 in the first trimester. The amniocentesis among all the women was positive for CMV in 14 or 8%, and that was significantly lower compared to the 30% that were positive for CMV in the placebo arm. So that proportion of positive amniocentesis was significantly lowered. And then when you look at that for women infected in the first trimester, it was 14 out of the 119 or 11 out of 23. So the odds ratio here is 0.15. These are tough because the timing is quite crucial, and you can see what a tight window that is to really identify women who would be at risk, but just a little bit of additional evidence that valacyclovir works in preventing vertical transmission for CMV after primary maternal infection, and specifically that efficacy in the peri-conception period. So none of the women infected in the peri-conception period who received treatment were positive for fetal infection on their amniocentesis.
Wow. Okay. The article Increase in False Positive Fourth Generation HIV Tests in Patients with COVID-19 Disease was published in CID. This actually came up today on our urgent care call. I think it's really important for providers and patients who might be getting an HIV test to be aware of this. In this article, they report that after looking at 31,910 medical records, they observed that in patients with a PCR confirmed COVID infection, the false positive rate for this can be easy to remember, fourth generation HIV test was 4 times higher.
Hmm.
All right, moving into bacterial. Be sure to listen to This Week in Microbiology. I'm in the middle of the latest episode at the moment. It's quite a good episode, I dare say. We often talk about antimicrobial stewardship, and here is an interesting article. It's going to get me in trouble with my urgent care comrades. Implementation of an antibiotic stewardship initiative in a large urgent care network, published in JAMA Network Open. Now, for background, as much as I applaud the pressure urgent care centers take, off the ER, urgent care center encounters result in more inappropriate antibiotic prescriptions than any other outpatient setting. Maybe outside of like agriculture where they're giving it to all the animals. But to make this worse, few stewardship interventions have focused on urgent care, kind of like the Wild West with Z-Pax, Augmentin, and Cipro for all. Now, every Wednesday at 1:30 p.m., I do a 30-minute call with the providers that work at our 100-plus urgent care centers in the New York tri-state area. I would like to think this is not going on here. Here, we read about a quality improvement study conducted in the urgent care network with 38 urgent care clinics. One telemedicine clinic included 493,724 total urgent care encounters. The study compared the antibiotic prescribing rates of all urgent care clinicians who encountered respiratory conditions for a 12-month baseline period, and then compared this to an intervention period. So 2018 through 2019, intervention period 2019 through 2020. And then they added a sustainability period after that. Now, the stewardship interventions included, number 1, education for clinicians and patients. 2, electronic health record tools. 3, a transparent clinician benchmarking dashboard. We're keeping an eye on you. And 4, media. Occurring independently but concurrent with the interventions, a stewardship measure was introduced by UC leadership into the quality measures, including money, a financial incentive. We will pay you more if you do a better job. The baseline period included 207,047 UC encounters for respiratory conditions. The intervention period included 183,893 encounters. Antibiotic prescribing for respiratory conditions decreased from 47.8% at baseline, ouch, to 33.3% with the intervention, and the antibiotic prescribing for respiratory conditions remained stable in the sustainability period. As I think this is really important, let me run through the details of what they did. So as mentioned, number 1, education. They had a UC antibiotic stewardship champion performing in-clinic education peer-to-peer. They had a handbook, which included guidelines, monthly update lectures. We're doing them weekly, by the way. Internal podcasts. Well, I feel like this is ours, with antibiotic stewardship leaders. That's you, Sara. Specific interventions for patients. They had the EHR tools, where every time you tried to give out that Z-Pack, you had a prescribing justification alert, where they basically said, what are you doing? Addition of delayed antibiotic prescriptions in the EHR. And then they had specific interventions for the clinicians, where they actually had transparent antibiotic prescribing dashboard, where basically you could see what folks were doing and a little bit more. So I just think that this is a huge target where we need to step in as we quickly plunge into the antimicrobial resistance apocalypse.
I think the dashboard, the comparisons with your peers may be very motivating.
For physicians, for clinicians in general, it's amazing how susceptible we are to competition and, dare I call it, peer pressure.
Yeah.
Out in Colorado, we had this assessment, like mammograms. Some docs were doing, great job, like 80-90% of target population. Then there were these other docs, oh, you don't understand my population. It's so challenging. I only can get 40 or 50%. When we started sharing that every 3 months, everybody was above 75%. Somehow.
Yeah, very motivating. Well, this next paper I'm pretty excited about. We've kind of talked about this topic off and on a couple of the other episodes, but in OFID, clindamycin and vancomycin versus linezolid for treatment of necrotizing soft tissue infection. This was a retrospective, single-center, quasi-experimental study evaluating, like the title said, Clinda and Vanc versus linezolid in combo with standard gram-negative and anaerobic therapy for the treatment of necrotizing soft tissue infection. They had a sort of pre-intervention period, which was 2018 to 2019, and a post-intervention period of 2020 to 2021, with a little bit of a gap there in the middle as the guideline locally was being developed. They included 274 patients with an ICD-10 diagnosis related to necrotizing soft tissue infection or Fournier's gangrene. Those with surgical management within 24 hours of their necrotizing soft tissue infection diagnosis, and patients who had at least one dose of linezolid or Clinda were included. So 164 patients met inclusion criteria, and they had 62 patients in the pre-intervention group and 102 in the post-intervention. And they took a look at 30-day mortality as their primary endpoint and found that in the matched cohort, there was no significant difference in mortality. It was 8% versus 6.5%. with a p-value of 0.65. They took a look at a couple other secondary outcomes. The rates of AKI were higher in the pre-intervention group, meaning the ones not leaning towards linezolid, so 9.7 versus 1.6 for the AKI rates. C. diff infection, there wasn't really a big difference. The composite of death, AKI, or C. diff infection within 30 days was more common in the pre-intervention group, 22% and 9.7%. And then there just were a couple other secondary outcomes that there really wasn't a difference. Total duration of antibiotics, time to improvement in their white blood cell count, when they stopped their pressors, how long they were in the ICU or the hospital. More patients in the pre-intervention group died within 60 days of surgery, 11.3% versus 4.8%, or 7 versus 3 patients. But the p-value is 0.22. And they also pointed out that thrombocytopenia, serotonin syndrome, and neuropathy were rare and not different between the two groups, even if they were getting the linezolid. So I think very exciting to have a somewhat larger clinical study looking at this question of can we use linezolid versus Clinda. There are obviously some limitations. It's single center and it's retrospective. And there are, for the types of bugs we worry about, there's not a ton of group A strep in this paper, but my personal bias is that I like having more data to suggest that we can use linezolid as a good option over clindamycin.
Yeah, I like the 6-fold reduction in AKI. That was kind of nice. All right. Yes, more articles to support my confirmation bias. Keep bringing them on. The article, Assessing Empiric Antimicrobial Therapy with the Modified Dundee Classification for Non-Purulent Skin and Soft Tissue Infections in a Community Hospital System, was published in OFID. A quick explainer. What is the Modified Dundee Classification? Who is using this? Well, first, there's sort of a severity score that is done where you say, yes or no, how sick are these people? Listen, if people are super sick, just go down the super sick sepsis road. But if you say no, and then you look at the amount of illness, then you break them down into class 1, class 2, class 3, class 4. So let me just sort of break this down. Class 4, right? As I was saying, critically unwell, septic. We're really going to go broad here, right? But what about the other side? Class 1, class 2, we see a lot of these. No systemic illness, no risk for failures of oral antibiotic therapy. Class 2 is where there is a risk failure for oral antibiotic therapy. And then class 3, right in between the two, systemically unwell, greater than or equal to 1 end-stage comorbidities. Maybe there's been a treatment failure to go into it. So the 2014 IDSA guidelines classify skin and soft tissue infections as non-purulent, including cellulitis, erysipelas, and necrotizing infection, or purulent, including those furuncles, carbuncles, and abscesses. Good old cefazolin is effective 96% of the time. 96% of the time. So MRSA coverage and broad-spectrum antibiotics should not be what everyone with non-purulent cellulitis gets in the ER. They found that overall concordance with the modified Dundee classification for the empiric emergency department and inpatient regimens were, are you ready for this? How well do we do? Only 10% and 15% respectively. 10% in the ED, 15% for folks getting admitted. How about put this way, 90% and then 85% of the time in this community hospitals, patients received the inappropriate antibiotics. Ugh. Should ID consults be mandatory? I think so.
Well, my next paper is a little bit of a change of pace from our last two. This one's from CID. Combination of amoxicillin 3,000 milligrams and probenecid versus 1,500 milligrams amoxicillin monotherapy for treating syphilis in patients with HIV, an open-label randomized controlled non-inferiority trial. In the UK guidance, amoxicillin plus probenecid is listed as an alternative therapy for syphilis, probenecid being used to increase the serum amoxicillin concentration. And there has been some signal that perhaps a lower dose amoxicillin would work. And this actually is in the Japanese guidelines, which I actually don't know that I knew some of this info before I read this paper. So, as you could tell from the title, open label randomized controlled non-inferiority trial, they compared the lower dose amoxicillin of 1,500 milligrams, so that's 500 milligrams 3 times a day for 14 days, versus a combination of 3 grams of amoxicillin and 3 times a day probenecid. And this is used for 14 days for early and 28 days for late syphilis. So they did exclude pregnant and lactating individuals, those, of course, with amoxicillin and probenecid allergies, neurosyphilis, and patients who had any sort of preceding antibiotics effective for syphilis. And they used a non-inferiority margin of 10%. Their primary outcome was cumulative serologic cure rate within 12 months post-transplant, so that RPR. 112 participants were randomized with about 56 in each group. These serologic cure rates within 12 months were 90.6% in the low-dose amox group and 94.4% in the combination regimen. In the per protocol analysis, the differences between the groups, that 95% confidence interval was negative 0.13 to 0.05 with a p-value of 0.13. The serologic cure rates, specifically looking at early syphilis, within 12 months were 93.5% and 97.9% with the low dose and combo regimens, respectively. And, sort of in conclusion, their non-inferiority was shown of the low dose amox compared to the combination overall, and for early syphilis was not confirmed. But this was really, it seems like one of the first RCTs to show high efficacy of the amoxicillin-based regimens for syphilis in patients with HIV, even though we didn't see non-inferiority with a lower dose for either overall early or late syphilis. There were no major side effects except for maybe a little bit more diarrhea in the combination regimen. Relatively small study, not necessarily against what I think we would consider the gold standard. But the other piece is probably a little hard to know if, it would be nice if the amoxicillin dose was the same, meaning it's hard to know if it's the probenecid or the increased dosing. You can't really tease that out. But I think those rates are, and this paper is really suggesting that we can offer amoxicillin if you can't provide IM penicillin, and have pretty high cure rates in that 90+% range.
Wow. You know, this came up today on our urgent care call because we have now, my partner Marilyn Fabry has now diagnosed in the last month her 4th case of secondary syphilis. That patient went for a biopsy. No one thought of it. No one did serology. It was seen on a
Oh, for
biopsy
the
of a
rash.
rash. Four in the last month. 3 of those actually had CNS involvement, tinnitus, otic involvement. So yeah, people, you got to raise the radar here. And I think a challenge is there's so much syphilis out there that we're actually running out of. We're having issues accessing IM, benzathine penicillin.
Yeah.
So, and one of the urgent care doctors suggested that maybe their inappropriate excessive use of amoxicillin would save the day, but no, let's not do it that way. Okay.
It's not exactly how we want to get there.
All right. Now, the article, "The sympathetic nervous system is necessary for development of CD4 T cell memory following Staphylococcus aureus infection," was published in JID, and I would say is fascinating. Now, lymph nodes and spleens are innervated by sympathetic nerve fibers that enter alongside arteries. There's some parasympathetic stuff going on that I'll ignore here for the moment. Here, the investigators found that chemical depletion of sympathetic nerve fibers compromised the ability of mice to develop protective immune memory to a Staph aureus infection. So, innate control of the primary infection was not impacted by sympathectomy. Germinal center formation was also compromised in nerve depleted animals. Protective antibody responses are still generated, but protective CD4 positive T cell memory failed to form in the absence of sympathetic nerves after Staph aureus infection. So I am wondering that maybe I am not doing my patients a service by being so calm and soothing. If I can rev them up and get that sympathetic nervous system fired up, maybe my patients will do a bit better.
In a bit of a follow-up from the Acinetobacter review I mentioned before, this is from the Lancet Infectious Diseases, Efficacy and Safety of Sulbactam Durlobactam versus Colistin for the treatment of patients with serious infections caused by Acinetobacter baumannii calcoaceticus complex. I'm just going to stick with Acinetobacter. A multi-center, randomized, active, controlled, phase 3, non-inferiority clinical trial, which somehow abbreviates to ATTACK, which I actually like. That's like a 4.5 stars for titles for a trial. So sulbactam durlobactam is a beta-lactamase inhibitor combo drug. This is a phase 3 RCT looking at the efficacy and safety of this drug versus the comparator colistin, and both had in the background imipenem cilastatin as background therapy. So 59 sites, 16 countries. These were adults with confirmed hospital-acquired bacterial pneumonia, ventilator-associated pneumonia, or bloodstream infection with Acinetobacter. They randomized patients 1-to-1 to receive this drug, sulbactam durlobactam, or colistin. The dosing for those, so the sulbactam durlobactam is 1 gram over why did I write that like that? It's Q6 dosing, and then the colistin was Q12 dosing. They received these drugs for 7 to 14 days with imipenem cilastatin in the background at Q6 dosing. So 181 patients were included. They are almost all pneumonia. There were 5 bloodstream infections. The 28-day all-cause mortality was 19% in the sulbactam durlobactam group and 32% in the colistin group. So that's a difference of about 13. This met the criteria for non-inferiority. The incidence of nephrotoxicity was also significantly lower in the sulbactam group compared to colistin, 13 versus 38%. So, sulbactam durlobactam was non-inferior for the primary endpoint of the 28-day all-cause mortality. It was better tolerated. And then after I added this article, I saw that the FDA actually approved this medication for Acinetobacter pneumonia. The trade name, you can help me. I think it Zacduro, Xacduro,
Zach
X
Duro.
Zacduro.
Just
I'm
say it
not
with
sure.
confidence. And then when you're
Zacduro.
wrong, you're confidently mistaken.
Yes, exactly.
You can be wrong, but never be in doubt.
Let's see. And then I have 2 fungal papers for us. The first one I actually picked up because I saw that it had also been in some popular press articles from MMWR Notes from the Field. First reported U.S. cases of tinea caused by Trichophyton indotineae, New York City, December 2021, March 2023. So this trichophyton infection has been emerging in South Asia, Europe, and Canada, and has been a highly transmissible cause of tinea corporis, tinea curis, and tinea faciae. Isolates are frequently resistant to terbinafine, which is a mainstay for tinea treatment. And so this had 2 cases, and what are the first reports in the US. So the first one was a 28-year-old woman in the 3rd trimester of pregnancy who did not improve with terbinafine and ultimately got better after 4 weeks of itraconazole. And the second patient was a 47-year-old woman who developed an eruption while traveling in Bangladesh and had multiple visits to care, ultimately received griseofulvin with about 80% improvement. And it sounds like it's sort of an ongoing case, and there's discussion about whether or not to use itraconazole. I think what's important to note is that her son and husband have similar eruptions that were undergoing workup and therapy at this time. So potentially a couple more cases there.
Yeah,
These
we're starting to see this in New York, Sarah.
Yeah, I
So
figured you may. I'm sure this has come up. It's interesting because it seems like the analysis and like identifying the correct ID actually required genomic sequencing, which I think is really important to note. But the MMWR article has some great photos in it. So important to think about, especially if a patient has widespread tinea and it's not getting better with topicals or oral terbinafine.
Yeah, the interesting thing that we saw in a couple of these cases is back in Indonesia, this has to have been going on for a while because there was sort of in discussions that came up that people are getting treated with itraconazole and getting better. And so I think they're just sort of saying, oh, that didn't work, and they're moving on. I think now we're realizing like this is a bit of a problem.
Yeah, it's pretty scary. And then the other fungal one I had was just a really nice narrative review. It's in Clinical Micro and Infection, How to Use Direct Microscopy for Diagnosing Fungal Infections. And hopefully everyone knows by now I am a sucker for really good figures or graphics. And the tables and figures in this article are really nice summaries of some of the characteristic elements of fungal pathogens under the microscope. They have a great flow chart starting with oval or round structures versus hyphae and pseudohyphae, blastoconidia, filaments. And there's also a really nice table 3 that I appreciated where they talk about the recovery of particular fungal pathogens based on the clinical specimen. And I previously had a CMR called Histopath Diagnosis of Fungal Infection by Dr. Garner and Brandt that every time it comes up, I bring that paper, but I may have to switch it up and replace it or supplement it with this one.
They are beautiful. I mean, I know, I know they're, but they're beautiful.
The images are so good.
Yeah.
So people should check it out.
All right. Moving into Parasitic. The article, well, I dare I skip over, listen to This Week in Parasitism. We got a great one coming up. The article, Limited Cutaneous Leishmaniasis as Ulcerated Verrucous Plaque on Leg, Tucson, Arizona, USA. I would have loved for this to be the unknown, but I think this might have been a little bit too hard. This was recently published in Emerging Infectious Diseases. This is a case report of a 34-year-old man with no significant past medical history who came to the dermatology clinic in Tucson, Arizona because of a new onset of a painless lesion on the right lateral lower leg. The lesion was present for 6 weeks before the visit. Physical examination demonstrated a 2.1 by 1.1 centimeter solitary non-healing verrucous plaque with central ulceration on the right proximal lateral pretibial region. Now, the patient reported considerable time outdoors and recreational activities such as mountain biking and hiking. Now, those activities occurred in Arizona. He specifically denied a history of recent travel outside of the United States. He also denied any trauma to the site of infection. Shave biopsy and subsequent staining with hematoxylin and niacin showed focal ulceration with mixed acute, chronic, and granulomatous inflammatory infiltrate and minute organisms in the cytoplasm of histiocytes, favoring parasitized histiocytic infections. The organisms were negative by staining with PAS. Microscopic exam was then completed by the CDC and P, and small intracellular organisms compatible with protozoal amastigotes were observed within macrophages. Immunohistochemical analysis subsequently confirmed a diagnosis of, yes, it was in the title, leishmaniasis. The patient was referred to an infectious disease department, finally, where observation was recommended because he had a solitary cutaneous lesion that was removed in entirety by biopsy. All right. I like this last one. Last one here in the parasites. The article, Can Ivermectin Kill Sarcoptes scabiei during the molting process? A friend of mine actually just came back from some time in Panama with a rash. And I'm like, oh, I'm certain it's scabies. Well, I don't think it was, but never miss an opportunity to harass a colleague. This article was published in PLOS Neglected Tropical Diseases. The answer apparently is yes, ivermectin can kill Sarcoptes scabiei, but maybe not quite. The activity of ivermectin on molting Sarcoptes mites was assessed, and while all female mites were killed after exposure to ivermectin, yes, but not all. Only 32 to 36% of the molting mites survived and successfully molted. That's like, what is that? Like a 68, 64? That's like a C or a D with different concentrations and exposure times, different amounts of killing, but still about a C or a D. Mites may survive after 2 doses of ivermectin given 7 days apart due not only to hatching eggs, but also to, as we see here, resistance of mites during their molting process. All right. This last one I'm going to sort of ask your thoughts on, Sarah. It's the article in Miscellaneous, the Infectious Disease Specialist at Risk of Extinction. This was recently published in JID. It's a perspective piece, and they have some interesting perspectives. Sarah, what are you thinking? Are we going extinct?
So I did read this one. I was going to add it if you didn't. I mean, I think that the authors point out things that we already knew. There's a focus on salaries relative to other sort of fellowship or hospital-based specialties, and sort of efforts that have been coming down. I mean, I think the main thing that they say that maybe is a little bit unique from some of the other things that are out there is about freezing the number of positions for fellowships and an effort to sort of equalize supply demand or not further exacerbate, I think, some of the geographic what should I say, like geographic distribution of ID specialists. But I don't know. I mean, I don't think it's one thing. Like, I mean, obviously I think there should be better reimbursement and compensation, but I think some of it is people's exposure to ID specialists, like earlier in training, which they talk a little bit about. I don't know how I feel about the freezing of the positions. Like, if that, I don't know how that sort of long term, if how much that will help. I do think it probably would impact where people go.
I mean, it's an interesting idea. If you have half the positions, you definitely fill a higher percent.
Yeah.
Shrinking the denominator.
Yeah. I guess the question is like where I don't know that I've looked recently on like where the newer spots they're opening. Are they opening in the more urban centers? They probably are.
Yeah. And do we need more
Places
ID
that need more
docs outside the urban centers? Are we sort of concentrated in the wrong areas from us serving the public? The interesting thing, I think a lot of it is the way the reimbursement works, right? We talked about an article where like 85-90% of people getting admitted to cellulitis are ending up on the wrong antibiotics. Those antibiotics are pricey. They're causing renal failure. It would be cheaper to, even if it's just a telehealth review, have someone look it over and be like, "Oops, sorry, let me fix those antibiotics for you." And it wouldn't have to be a huge compensation, but overall, it could be a net savings financially. It also could be a much better patient experience if you're not getting unnecessary toxic antibiotics.
Yeah, like how do we make the art and science of antibiotics sort of exclusive to us at ID, or more exclusive?
Yeah.
I think it all kind of stems back to that.
Yeah, I mean, a lot of hospitals, right? When you prescribe a certain medication, it goes through pharmacy review. If you prescribe an antibiotic, not a big deal to have a system where there is an infectious disease physician reviewing it and having some sort of compensation for the benefit that provides.
Yeah.
And all right, as I mentioned, my bow tie, we are here. This
Full
is the
circle.
most frightening of all the articles I have read in many years, dare I say. The article, Ticks Harbor and Excrete Chronic Wasting Disease Prions, was published in Scientific Reports. In this very interesting study, the results suggested that ticks can take up transmission-relevant amounts of infectious prions, affecting cervids, those are those deer-type organisms, and may allow for the spread of prion disease among deer when they ingest them as part of their allo-grooming activities that result in tick ingestion. Ouch.
Well, on that note, that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We love to get your questions, comments, paper suggestions, just words of just love and how much you enjoy us. That's always great. Send them to puscast@microbe.tv. If you like what we do, if you think what we do is important and you want this to continue, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or go to Parasites Without Borders, parasiteswithoutborders.com, and click on the donate button.
I'm Sara Dong. You can find me on Twitter at swindong, at Febrile Podcast, or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at parasiteswithoutborders.com, on Twitter at Daniel Griffin MD, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.